Hello, good morning, everyone. My name is Chris Karate. I'm Vice President of Communications and Events at The Washington Post. Thank you for joining us for the latest in our ongoing series, Addiction in America, which examines the impact of the nation's opioid epidemic on communities across the country. The Washington Post newsroom has done groundbreaking reporting on this issue, including an Emmy Award-winning joint Washington Post-CBS News 60 Minutes investigation that led to the withdrawal of President Trump's nominee to head the Office of National Drug Control Policy last year. Despite the national spotlight on this ongoing public health crisis, solutions have been hard to come by, and the numbers paint a grim picture. Just last week, the Centers for Disease Control and Prevention released statistics showing that drug overdoses claimed more than 70,000 lives in 2017. Deaths attributed to the opioid epidemic were nearly 6 times greater last year than they were in 1999. Today, we're going to hear from the nation's top doctor, drug policy experts, and community leaders on the front lines of the crisis about how to reverse the trend through new treatment programs and early intervention. Before we get started, I'd like to thank our presenting sponsor for this program, SAS, and our supporting sponsor, Leidos. Now, please welcome Dr. Steve Kearney, U.S. Government Medical Director at SAS, for some remarks.
I want to thank the Washington Post for their leadership regarding this series addressing the opioid epidemic. And thank you to the speakers today for all their tireless work. You are truly on the front lines of this battle. I am proud to be a part of a company which uses data to solve humanitarian issues around poverty, health, human rights, education, and the environment. At SAS, we believe that some people look at data and see numbers. We look at numbers and see faces. In regard to the opioid epidemic, we see the faces of all those loved ones that have been lost, those struggling with addiction, and we try to see the future. The data to change this is there, but it is siloed in fragmented formats, most times too large to deal with, and is not actionable. I'd like to share with you today, though, a fresh look at the data in those faces. I want to talk to you about the ones on the front lines, all of you that are watching today and those of you in the audience. My first real insights into the epidemic came years ago from Sheriff Asa Buck in Carteret County, North Carolina. I was doing a provider training program on pain management for Project Lazarus. Sheriff Buck brought his entire leadership team to a 3-hour provider training program. At the end of that program, he asked one question: is there a single provider in the room, if I brought them a patient, they would provide treatment? You see, Sheriff Buck did not want to arrest the PTA mom that was addicted to opioids because of a flawed system. He wanted to get her help, but he didn't have the data. The second face that I see is that of Scott Proscobel, an epidemiologist with the Injury Prevention Group in North Carolina. Scott is phenomenal at what he does and a national thought leader. Most times he was my sole source of truth and data during the early days of our provider training at Project Lazarus. Scott is a true leader, but he was well aware of the fragmented system that he was working with. Fast forward to my past few years here at SAS. I've been fortunate to travel the U.S. to help our SAS teams bring the fight to the epidemic while partnering with state and federal leaders. We started like everyone else did, with prescription drug monitoring programs. One on the East Coast, one on the West Coast. The administrators were dealing with millions of prescriptions, very little actionable data, and systems that were so poorly funded, they were poorly operational. One was able to automate their system and get analytic insights. The other had to settle for the status quo. We can't have that type of inequality and expect different outcomes. Our teams met with states, governors, Congress, all the major federal agencies tackling the opioid epidemic? Guess what? Those federal agencies use base SAS, but have it in siloed environments that can't be shared across agencies, and many times can't be shared within agencies due to legal and regulatory restrictions. But there is some good news. The Office of Inspector General published a toolkit this year and is sharing the base code from insights they gained from CMS data. It's not advanced analytics, but it's a start. One state combined 10 data sets from 5 agencies to make a policy change that has resulted in a 6% reduction in 2017 of opioid overdoses. The state of New Jersey is combining and analyzing law enforcement data, arrests, shootings, toxicology, naloxone administrations, and prescription drug monitoring program data in an interactive, actionable environment. 10 states, all the federal agencies that we met with, are looking at breaking down data silos, exploring the use of machine learning, and are asking us for guidance on artificial intelligence. At SAS, we are constantly learning. We're spreading the word. We're bringing more people into the analytics community to fuel the journey toward improving lives of others. To that end, today we would like to announce a new SAS users group to tackle this epidemic. We believe that we discover the best version of what's possible by striving for the best version of ourselves. Our SAS users drive that innovation and demand the best. In the words of our founder, Dr. Jim Goodnight, if you treat people like they make a difference, they will. This SAS group will make a difference. With our SAS users groups, data scientists, systems engineers, 40 years of analytic insights, and most importantly, all of you, we can change this epidemic. We can all use data for good. Thank you.
By sprayer injection is the powerful and controversial drug that pulls opioid addicts back from the brink of death. Today, the Surgeon General urging more Americans to have this drug on hand to fight the epidemic ravaging the nation's families and neighborhoods. Dr. Adams says more than half of opioid overdoses happen at home, killing someone every 12 and a half minutes. So he wants naloxone to be as common as EpiPens or defibrillators. But critics say it just revives addicts so they can use again.
The alternative is just letting someone die. I don't think it's the individual's fault. I think it's the system's fault.
Welcome, everyone. Thank you for being with us today. We're very on. I'm Lenny Bernstein, by the way. I'm a health and medicine reporter here at the Washington Post. And today we are honored to have Surgeon General Jerome Adams with us. We're going to talk about the opioid crisis and what the federal government has been doing to help with the opioid crisis. Before we begin, I want to remind you that if you want to ask a question of Dr. Adams, you can tweet it to us. Please use the hashtag #PostLive. I'll get them on this iPad if I can figure out how to work it. And then I will pose the question to Dr. Adams. So welcome. Thank you for being here with us.
Glad to be here, Lenny.
The numbers we got last week, we can't ignore them. Life expectancy down again, 70,000 deaths from drug overdoses in 2017. For people's context, that's about 200 a day, or if twice the number of people in this room were to die every day of a drug overdose.
It's like a 747 jet dropping out of the sky each and every day.
And 48,000 from fentanyl. Do you ever just sort of step back and say, how do we get here? How did things get so out of control?
Every day, and it's one of the things I'm trying to help folks understand, is that this is a once-in-a-generation type of problem. And you wrote a great article about this just a while back, speaking of the fact that we haven't had 3 years in a row where we have had either a decline or a steady state since going back to World War I. I often think about the HIV epidemic that occurred 30 years ago, and our kids are going to grow up and remember this time as a critical moment in their history. I represent the first generation of parents in 50 years who, as of right now, can't look their own kids in the eye and say, you're going to live a longer life than I did.
Wow, that's amazing. It's becoming largely fentanyl. The number of deaths from prescription narcotics and from heroin thankfully leveled off in 2017, but fentanyl deaths are continuing to go through the roof. What do we do about fentanyl in this country?
Well, it shows the importance of partnering with law enforcement. I was in Boston just yesterday at an event with over 400 law enforcement officers. It shows that we can't solve this problem in our traditional silos. We know a lot of the fentanyl is coming in from out of the country, and the administration is really leaning into enforcement. But I also think it's important that we remember this epidemic had 3 phases. Phase 1 was a overprescribing epidemic, and I was part of that. I was taught 20 years ago that pain is the 5th vital sign, and that if you gave people opioids for pain, it wouldn't cause them any problems. And I taught that to my residents and medical students. We cracked down on prescribing.
If I could interrupt, yes. I think people in this era, just that sort of boggles the mind. How did we come to teach that they would not get addicted to opioids?
Well, that's a great question, too. You know, the fact is that 60% of people who misuse opioids are misusing them to treat pain. And so we pat ourselves on the back for driving down opioid prescribing rates. But my challenge to providers and to America in particular is don't just look at the decrease in opioid prescribing unless you're plotting it against the increased availability of pain management modalities, because otherwise you're just sending people from one place to another to another. So we cracked down on opioid prescribing. People jumped over to heroin. Phase 2 was a heroin epidemic, and we saw hepatitis rates go up. We saw the HIV epidemic in Scott County. And now we're seeing a tremendous increase in overdoses because of the involvement in fentanyl. But we have to remember that even though it is now largely a fentanyl epidemic that's responsible for overdoses, the majority of folks who misuse still get started with a prescription opioid. And so we can't forget that that is the beginning of this pathway for so many folks.
If we were somehow able to halt the flow of fentanyl, is there another drug that's coming behind fentanyl that we need to worry about?
Well, there's always going to be another drug if we only focus on the supply side. We've got to focus on the demand side also, and that goes back to making sure we're appropriately treating pain. I mean, in my mind, there are 3 reasons that people misuse. One is ignorance, and there are a lot of young people out there who don't know these medications are dangerous because they come in a pill that says doctor written on the side. So we're raising awareness amongst youth. Number 2 is chronic pain, legitimate chronic pain, and we need to make sure we're treating acute and chronic pain appropriately. We need to make sure that we're doing that. And the 3rd reason for people misusing is physical pain, mental pain and anguish. It's depression, it's anxiety. It's how my brother's pathway got started. And until we get serious about addressing mental health issues, we're also going to continue to see folks jump from one drug to the next.
So folks are self-medicating.
Exactly.
They feel depressed, they take an opioid, and an addiction occurs. I was going to ask you next about your brother. Would you mind sharing the story with our folks who are watching here and online?
Absolutely. You know, my brother Philip, my baby brother, is in prison in Maryland, not far from here right now. He had unrecognized, untreated anxiety and depression, self-medicated with alcohol, with tobacco, with marijuana. And then one day he went to a party and someone gave him a pill. And it was like a light switch. And that rapidly went into injection drug use, him committing crimes to support his habit. And he stole $200 and got a 10-year prison sentence. And I share his story, not because it's unique, but because unfortunately, it is the story of America. In every community you go into in America, there is someone who has that same story. And we've got to start to look at this epidemic is something that really does affect all of us.
10-year prison sentence for $200 theft? How did that happen?
Well, I don't want to diminish the importance of public safety and of making sure people are responsible for their crimes. But again, I share the story because it helps lower stigma, but also because at $100 to $200 a day to incarcerate someone, it's going to cost the taxpayers hundreds of thousands of dollars to incarcerate my brother, only to put him back out and do the same thing over and over again because he's still not getting treatment. There has got to be a better way. If we had spent $1,000 on him up front to get him treatment for his anxiety, if we'd spent $50 up front to get him into an after-school program where he could build some resilience. So many places that we miss to intervene that ultimately turn into hundreds of thousands of dollars, millions of dollars that this country is wasting to try to punish a chronic disease.
That's incredible. That's an incredible story. Let's talk about what we are doing. What is it feels, even though the epidemic is still horrible, it does feel like in the past 2 or 3 years, the government and other parts of society have begun to mobilize. We're not anywhere close yet, but people are in the phase where they're doing things. What's the federal government doing?
The federal government, for the first time ever, the administration has all of the different agencies coming together on a regular basis to make sure, number one, we're talking to each other. So Department of Justice, Health and Human Services, Education, Labor are all coming together to figure out how this is impacting them and how we can lean in together and combine our resources. And I mentioned labor, 6 million unfilled jobs in our country right now. More unfilled jobs than there are people looking for work. This opioid epidemic is not just something that affects my brother or affects me and our family. It affects all of us, our competitiveness, our ability to continue on this economic upswing. The government has put out $2 billion, more money than has ever been dedicated to the opioid epidemic. Folks say it's not enough. What I will say is we can't spend our way out of the problem. We need to work smarter in addition to working harder and, again, find ways to break down the silos and different funding streams so that we all can pool our resources to work together. But I'm also focused on making sure that money gets to local communities. I used to run the State Department of Health in Indiana, and one of the frustrations was that the money, we'd hear about it on TV, but it never seemed like it made it down to the community level.
How is that possible?
Well, you know, it's hard to distribute money across the United States, and so it gets allocated here, it goes to the states, then the states have to allocate it to the communities, and then the communities then divvy it up amongst the smaller groups. And one of the things we're trying to do, this administration is really trying to do, is make sure that money gets there so much more quickly, looking at new models to fund different programs so that some places can apply directly instead of having to go through a lot of the circuitous routes to get that funding.
Mm-hmm. What is some of the money going towards at the community level? What's being done?
Well, I'm proud to say that after I put out our naloxone advisory, the first Surgeon General's advisory in over 13 years, that naloxone prescribing is up over 350%. We know that the communities that have been able to turn around this opioid epidemic have really leaned into saturation with naloxone.
Sorry to interrupt, Dr. Adams. For people who don't know, what is naloxone and what does it do?
Naloxone is a very safe medication that is an antidote to an opioid overdose. Over 50% of the overdoses that are occurring in a home environment, in a garage, in a bedroom, in a bathroom, and brain death occurs within 4 minutes. So until we can invent an ambulance that can teleport to your house in 4 minutes, we need to make sure everyone understands that they can and need to carry naloxone if they are at risk of encountering someone who's having an overdose, which right now is most of us. And so we're really making sure communities can access naloxone. We're expanding treatment and trying to break down barriers so that we can have more both inpatient treatment and outpatient treatment through things such as telemedicine, Project Echo. We need folks to understand that we will never be able to have enough inpatient beds to meet the need. We've got to start looking at different models of care, and we're promoting those models of care. NIH is also looking at alternatives to opioids for pain management, and FDA is trying to approving those alternatives at a rapid rate, because again, if we don't treat this epidemic of chronic pain, that precipitated the opioid epidemic, then the pendulum's just going to swing all the way back to where it was again. Well,
so you're doing perfect. You keep raising my next question.
all right.
And my next question was going to be, we know what works in terms of treatment. People need to be on buprenorphine, methadone, some form of medically assisted treatment, because as you say, we're never going to have enough beds. Not everyone can be treated that way. So we live in a nation where I can get my hands on blood pressure medication, and so can everybody else. Why in America do we have only 10% or 15% of the people able to get their hands on buprenorphine?
That is a challenge, and I was at Harvard Medical School just yesterday in Boston, challenging our care providers to make sure more folks have pain management training, number one, but number two, are willing to be data waivered so that they can prescribe buprenorphine. I want every, at least primary care physician, OBGYN, ER doc, to be trained to actually prescribe medication-assisted treatment. We don't have enough providers. We've also got stigma attached to medication-assisted treatment. We need to help folks understand that we're not enabling addiction, we're enabling recovery when we provide people with medication-assisted treatment. And those are areas, again, that I'm leaning in on as Surgeon General: education of providers, education of the community, fighting stigma.
But there are barriers to being a doc who wants to prescribe buprenorphine. Even if I did, right? I have to get some special training, I need a waiver. Can't we clear that out of the way?
Well, that's one of the things we're trying to explore. It's interesting. There's a saying, the pathway to hell is paved with good intentions. There are many well-meaning policies that we enact that then have terrible consequences. One of them was pain as the fifth vital sign. The fact is, when you talk to folks who run jails and prisons, they will tell you one of the top products that they confiscate in terms of contraband is buprenorphine. So I hesitate to say that because I don't want to give it a black mark, but the reality is we need to make sure we're increasing availability to those who need it, but not creating another epidemic or problem out there. And that's why we're being very careful when we look at the data waiver process and really leaning into now making sure folks are better trained and that healthcare systems are creating an environment that makes it easier for providers to get trained and to prescribe.
So you mentioned the $2 billion that the government is spending. I presume that includes the legislation that Congress passed.
Yes.
Is the Trump administration doing enough to curb the opioid crisis, in your opinion?
Well, the reality is we all need to ask ourselves if we're doing enough and what more we can do. We all need to ask ourselves which partners aren't at the table. Again, how can we work smarter instead of working harder? And the reality is we need to do both. What I can say about the administration is they're doing more than any other administration has done to tackle the opioid epidemic. The president has been unafraid to take on the pharmaceutical companies and some of the other interest groups out there that have traditionally held back progress on this issue. And again, I want folks to understand that we aren't going to solve this problem from Washington, D.C. We're not. I feel our job in the federal government is to educate, to lift up best practices, and to enable local innovation so that folks can solve this problem locally where the problem is occurring.
We've talked about pain and taking steps to keep people from becoming addicted through legitimate medication. We've talked about the other ways that folks get addicted, but a large part of this problem is a mental health problem. Mm-hmm. What are we doing about mental health funding? And given what you said about money getting to communities, what are we doing about getting money onto the streets and services onto the streets to address mental health?
That's a great question, and I'm going to answer it perhaps in a wider way. The opioid epidemic is a terrible tragedy, but it's also a tremendous opportunity. And what do I mean there? 10 years ago, I would have never been able to get 400 police officers to come together in a room to talk about a public health issue. There are folks coming to the table like never before, CEOs, priests, and faith leaders, teachers, to talk about a public health issue. And what I want us not to do is to focus so much on putting out the fire that we don't lean into fire prevention. And what is fire prevention? It's creating health and wellness in our communities. It's addressing mental health issues. You asked specifically what I'm doing. I'll tell you, I'm talking to providers to make sure we're integrating behavioral health services into primary care, that we stop looking at behavioral health services as a add-on and instead look at it as a value add to the patient care encounter.
So you would like to see mental health be taken care of by the primary care doc?
Well, that's the only way. We aren't going to have enough psychiatrists or psychologists out there to give every single person direct access. We need folks to understand that we can't separate the mind from the body physically, and we shouldn't do it in the care encounter. At every care encounter, you should be screened for risk factors for substance misuse, for suicide, which is another reason life expectancy is declining, for all of the potential things that if we catch them earlier, prevent folks from turning into my brother down the road in prison for 10 years, costing the taxpayer hundreds of thousands of dollars.
One more I'm going to ask you about that when I go around and I interview people with substance abuse disorders, usually at treatment facilities and places like that, there's a tremendous correlation between childhood abuse and addiction, particularly when it comes to heroin. Are we working on that? Are we doing anything to try to curb the amount of abuse in the home, which seems to be one of our most intractable problems, but are we doing anything about it?
So again, the wider window there is what we call adverse childhood experiences. And we know that if someone suffers from an adverse childhood experience, and over 50% of us do, that you are much more likely to become pregnant as a teenager, to not finish high school, to not have a job or have a low-paying job, to engage in criminal behavior, to become a victim of substance use disorder. And so I'm working as the Surgeon General with others within the Department of Health and Human Services and beyond to lift up this issue of adverse childhood experiences, but also of resilience. We know that everyone who has an adverse childhood experience doesn't have a bad outcome as an adult. So what are the factors that put you on the pathway to success as opposed to on the pathway to negative outcomes?
Here's a question from Twitter. How much will the increased legalization of marijuana lead to increased addiction to other drugs like opioids and heroin?
That is a great question, and the marijuana issue is a little bit too complicated to unpack in this setting, but it's important that we understand that there's a difference between the discussion of the medicinal properties of marijuana. And I don't say medical marijuana because there's no such thing as medical marijuana any more than there's a such thing as medical poppy, which is the plant from which heroin and opioids are derived. There are medicinal components of marijuana. There's a difference between that and looking at our criminal laws, which again do need to be looked at. It shouldn't be a 10-year prison sentence in one state and a slap on the wrist in another state. And we also need to look at the recreational side of things, recreational use. And from that point of view, I'd tell you it would be incredibly disingenuous of me as Surgeon General to say you shouldn't smoke a cigarette, but I'm fine for you to go and light up a joint. But that said, we know that marijuana primes the brain for further addiction, as it did in my brother. That it can cause developmental delay, particularly in the young and developing brain. And we still don't know the effects it can have on the rest of the body, particularly if you're smoking it. If cigarettes cause cancer, there's every reason to believe that long-term usage of marijuana can cause cancer.
Okay, so you're America's doctor. That's your nickname. You're, in a way, the doctor for all of these folks.
I'm just dad at home. My kids don't care that I'm the Surgeon General.
Except when you're wearing the uniform.
Yeah.
They love the uniform. In the time we have remaining, if the average citizen wants to do something about this, I don't work for government, I don't work for anyone who has power or authority to do anything about this problem, what can I do?
Well, 30 years ago, C. Everett Koop sent out a letter to every household in America called Understanding AIDS, because he was dealing with an epidemic and he wanted all of America to understand they could play a role. Well, I wanted to do the same thing for the opioid epidemic because, again, I believe it's a generation-defining problem. But they told me it was going to cost $50+ million to do that. And more importantly, my kids said, Dad, nobody reads mail from the mailbox anymore anyway. So what I did was put out a digital postcard. It lists 5 steps that every American can take, every American to respond to the opioid epidemic. But it's a digital postcard. It's on my website, surgeongeneral.gov. And I ask all of you all to go to that website, view my digital postcard, determine the steps that you can take, but more importantly, please share it through your social media channels so that we can get it to every household in America. Because the fact is, this opioid epidemic is like an elephant that's sitting in front of us. And everyone looks at it and says, I can't eat that elephant. And so they start pointing fingers and saying, you need to do it. No, it's your fault. No, you need to do it. But the way we're going to eat that elephant is both one bite at a time and with everyone cooperating and taking their own individual bite. And so here's how each of you can play a part in responding to the opioid epidemic. Go to my website, view, download, and share my digital postcard. We all have a role to play.
Terrific. Thank you so much. I want to thank the Surgeon General for being with us today. That's all the time we have for this panel. And then we will move on to the next one.
Thank you, Lenny.
Great.
This is where the hills of Appalachia flatten into the Midwest. It is small town America. Like other parts of the country that see opioid addictions rise, it's a place where jobs and people have come and gone. A place where pain pills poured in, followed by heroin, cheap and available, like beer.
We're seeing overdoses at an epidemic proportion. We're seeing the use among individuals from all walks of life in our community.
It's kind of taken on a life of its own just simply by the resources that are required to be dedicated to the efforts in stopping people from killing themselves.
People here say the addiction epidemic used to be talked about in whispers, if talked about at all. Then people started talking about addictions and overdoses.
We've not closed our doors. We've not rolled up our community streets. We've really come together with the idea that we're going to battle this epidemic.
I came here basically to wake somebody up. I've been arrested 98 times here in Ross County. Learn what not to do. They gathered beneath the banner that says drug-free in a town that is not yet.
It took you children to come together and start something so the rest of us can follow.
What there is hope for the 1,500 students on the street in Chillicothe, Ross County, Ohio.
So welcome everyone. I'm Katie Zesma. I'm a national reporter for the Washington Post, and I'm delighted and honored to welcome my guests who are all leaders on the front lines of combating the opioid crisis, which is the worst addiction epidemic this country has ever seen. So we have Tracy Green, who's an epidemiologist and the deputy director of the Injury Prevention Research Center at Boston Medical Center. Dr. Roger Mitchell, the chief medical examiner of the District of Columbia, who's an expert on the social determinants of the opioid crisis from his perspective on the ground here in the district. Regina LaBelle, a distinguished scholar and director for the Addiction and Public Policy Initiative at the O'Neill Institute for National and Global Health Law at Georgetown. She's also chief of staff at the White House Office of National Drug Control Policy under President Obama. And Tom Synan, who is the chief of police in Newtown, Ohio. Tom has worked with addicts in his community's prisons. He's co-founder of the Hamilton County Heroin Coalition, a group that provides countywide leadership and solutions to address the heroin and opiate epidemic immediately and in the long term. And as a reminder to everyone that you can tweet your questions. Please tweet your questions. Let us know what you want to know using the hashtag #PostLive. So let's get started. You know, this is a panel about being on the front lines of the opioid crisis. So we obviously want to know what's happening. So Tom, what does this epidemic look like in Hamilton County? Kind of what do you see every day on the ground? And you know, what's happening to try to make things better?
Well, give you a little background. I'm a police chief of a very small town, about 3,000 people, 11 miles east of downtown Cincinnati. I've been there for going on 26 years, but in my 21 years, I watched an entire family die from addiction. Mother from abusing prescription pills and alcohol. Youngest brother was shot and killed by crack cocaine. Oldest brother overdosed on heroin, and then the last brother overdosed on heroin. Entire generation gone. They have kids. Those kids are now being raised by their grandparents. Me, this small town, impacted by 3 generations. So that is the bad part of it, but what it did, it kind of was a catalyst for us to change and for us in law enforcement to say, wait a minute, this is beyond us. We need to reach out to some other experts and we need to work together. And that was the formation of the Hamilton County Heroin Coalition. Everything from prevention, local elected officials, state, federal, prevention, harm. I tell people my best friend is now the health commissioner. 4 or 5 years ago, I didn't even know what a health commissioner was, but we worked together and we're putting Narcan on the street. We're changing how we do this, how we look at this addiction. We're changing how we view and deal with it, which is really important. And I'm glad that law enforcement are some of the first ones to step up and say we need to change.
And I know, Tracy, you work in both Boston and Rhode Island, and I know that in Rhode Island you're doing some interesting things in terms of partnering with, pharmacies and other places to try to get medication-assisted treatment into the hands of people. Can you talk a little bit about that?
Yeah, I think for fentanyl's brought a lot of horror into New England in particular, which has always been a place where opioid use disorder has been a serious problem. But it also has brought hope and new partnerships, new collaborations with law enforcement, and an important recalibration of the care that we provide. And so for medications for addiction treatment, which are the evidence-based life-saving medications that we need, we understood from fentanyl we needed them in more places. And so one of the things we learned is that the incarceration is a strong connection for fentanyl, and the importance of focusing on criminal justice populations and giving people a pathway for hope. So thinking about correctional systems as a place to provide medications for addiction treatment, but also when they leave, we need a place in the community for people to go. We can ramp up treatment with providers, prescribers, community health systems, but we also need new partnerships. And one way that we've been innovating is thinking about pharmacies. So we've recently invited partnerships with Genoa Pharmacy to think about providing medication maintenance medications, specifically buprenorphine and naltrexone, in the pharmacy, and that's been amazing and transformative, and also a simple pathway for our criminal justice system to have another partner in the community there.
Can you talk a little bit about why it's so important to reach people when they're in jail and when they're in prison, and to get them addiction treatment when they're there? Why it's important to do that at that moment, before they come back out, onto the streets?
I'm an epidemiologist, and I study drug overdose for 20 years looking at these patterns. And worldwide, nationally, and in Rhode Island and Massachusetts, every state, we see a very, very strong connection between formerly incarcerated populations and risk of overdose. Some of the highest risk of mortality within even a short period of time, 2 weeks. 153 times more likely to die of a drug overdose for folks who are leaving incarceration. So this is an opportunity for huge change. Medications for addiction treatment in an incarceration setting will have an enormous benefit. So that was one of the things that is so important, because the change in tolerance, where people who have not been using an opioid for a long time, their bodies change, and when they leave and may return to use, they suffer an overdose very quickly. With fentanyl, it's even faster and more lethal. So it was even more important to put medications and evidence-based life-saving medication behind the walls. So that's what we did. And we saw a 61% reduction in mortality in 6 months by creating a state-based system. This was profound and is really not seen in public health or pretty much anywhere, that we can make some enormous change.
And Dr. Mitchell, I want to talk to you about here in the district. Fentanyl has really been decimating the district, and a lot of people look back to the war on drugs and the crack cocaine epidemic of the 80s, when people, typically young black men, were put in jail for using drugs. Now with this opioid epidemic, the focus has been on treatment. And as someone who's here in the district, which saw some of the worst effects of the war on drugs and is now seeing huge numbers of people die from fentanyl, can you talk about the differences between the two epidemics and kind of what you're seeing on the ground right now, and how urban areas are responding to it slightly differently than rural areas are?
I appreciate that. Back in 2014, we had 83 opioid-related deaths in the district. And remember, our population has just grown to 700,000. In 2017, we had 279 deaths due to opioid-related or substance use disorder with opioids. What's important to note is that about 80 to 90% of our opioid-related deaths have fentanyl on board. Fentanyl is the culprit throughout the country. And why is it the culprit here in the district is our deaths are a little bit different than the rest of the country. These are 50 to 60-year-old black men. These are men that are chronic users, that have substance use disorder, that have the disease of substance use disorder. And now you add fentanyl, which is 50 to 100 times more potent, than regular heroin, there's no way to titrate that. And so we continue to see that. We have, in 2017, we had 23 every month of opioid-related deaths, and in this year we're at 17 every month. And so the district has an approach to this that is age-specific. We know the demographic. We utilize the medical examiner data as well as our fire and EMS data to develop solutions. We're giving out 400 naloxone kits every month. Needle exchange is robust. And so the work has to be focused on specific to the populations affected, and understanding that the urban centers in this country are also facing this epidemic in a way that's decimating families. And so it's not just the young white man that's 20 to 40, it's the older black man that's 50 to 60.
And, fentanyl is seen as kind of the third wave of this epidemic. You had pills, you had heroin, you have fentanyl. Regina, is there a fourth wave? And if so, what is it?
Well, I don't know if I'm skilled enough to predict the fourth wave, but I'll tell you what I'm hearing. In states such as Kentucky, in a lot of rural areas, they're seeing a resurgence in methamphetamine, and they will say it's not a resurgence, it's always been there. But the issue is that we now have liquid meth, and I'd be curious to see what you think about this too, Chief. This is the bad news is we have a resurgence of liquid meth in these areas that is being injected. Now, the good news is in a state like Kentucky, they have 50 syringe service programs in that state. They are poised now to address that if they can pivot to the type of services that are needed for, because again, the good thing about this is you call it the addiction issue. It's because it's not, we need to make sure we're not only focusing on opioids and what the substance of the day is. So I think we're likely to see, continue to see increases in methamphetamine and in the consequences relating to the injection of meth, because what we've seen is the manufacturing of meth is a little different than it was the last time we had a lot more meth in this country, and so if there were a fourth wave, that's what I would say.
And what are some of those consequences, of meth, especially, when they're used in concert with opioids, which we're seeing, I know, increasingly on the streets? So. Anyone?
I was going to say, you bring up a really good point, and part of that is that's why these collaborations are so important. Look, there's an ebb and flow of drugs. We have never gotten rid of addiction. We're chasing one drug after another, and these collaborations are really important with health, with the federal government, with the streets, with the communities. That's why these collaborations are so important, especially when you're talking about needle exchange. Now, the next epidemic that comes along, we're better prepared than we were before. We're seeing a mixture of all kinds of drugs. We were talking about this before. There's some people, and here's the thing, it's not just one particular item. It is several things. So from some of the intelligence we get on the street, it is some people are worried about fentanyl and they don't want to die from the fentanyl, so they've been switching to the new crystal ice, methamphetamine, crack cocaine, or cocaine. There's some people who are speedballing it, and that was something that you did back in the 70s with heroin and cocaine. There are some drug dealers, now remember, these aren't doctors, scientists, and pharmacists who will tell users, hey, if you don't want to die from fentanyl, use methamphetamine or cocaine and it'll counter those effects. So from our perspective, from the government side, it's really important that we remain flexible and vigilant, because these items and these trends continue in this ebb and flow and are always changing. And drug dealers and cartels are always looking for the next more powerful drug that'll get people addicted and make more money. So synthetics is my big concern on the next drug wave.
And I would add, I don't think it can go understated that we're really dealing with substance use disorder as a disease. And so what fuels individuals to decide to utilize drugs to numb their own pain? And whether or not that's access to education, economics, housing, criminal justice practices, whatever those upstream type of issues that make substance use a choice, is where public health has to work in that space. And that's critically important as far as how drugs and what are the new drugs. In what I see, and these are the deaths of individuals, it's always mixed drug toxicity. So we can talk about opioids and fentanyl, but the majority of them also have cocaine on board, or PCP in the district, right? And so it's yes, there's specific things that we want to know about these substances and how to prevent and support the user, because there's different profiles for the user. But we also have to realize that the substance use disorder construct is what we really need to be focusing on.
One thought, or two thoughts just to add to these wonderful points from my colleagues, but one is that drug use is all about geography and history and humanity. And I think we need to understand a lot about the history. We don't see the same patterns of methamphetamine in some parts of the country that we do in others. And we see a lot more cocaine in some of those other communities. That stimulants are there, but they take different forms. So really thinking as partners in law enforcement and public safety and public policy to really think about that, the importance of geography and how we may need to have some basic responses like naloxone and medications for addiction treatment that work across these, and contingency management and behavioral treatments that work for stimulants and opioid use disorder, and also think about the nuances of how we're going to reach those individuals. One thought, though, for fentanyl that's different is that fentanyl has another dimension that we're not really fully appreciating, and that is the contamination factor. That we need to think about the fact that fentanyl, because it's so small and can find its way in those same powders and pills, that we need to think about how to detect, how to respond, how to communicate effectively to people who are using these other substances who unsuspectingly are taking them into their bodies and unfortunately seeing you. So we need to think about how to communicate to people who use drugs and to communities to make sure that contamination, just like we have if it's a romaine lettuce outbreak, we need to be able to communicate and talk to the people who may be exposed, because contamination and product safety and consumer safety is a component that's unique to fentanyl.
Can you talk a little bit how you do that?
Well, I'm hoping that we can think a little bit more on the harm reduction front. Some ways, simply, we may be able to, as people are exposed, to understand and look at our emergency department trends and toxicology tests that occur at that level, certainly at the medical examiner level. But it would even be better if people didn't have to be exposed to and experience these things that are negative. So we could learn how to test the drug supply, for instance. There's emerging evidence about fentanyl drug testing, especially these fentanyl test strips, but also other machines that may be able to give us insight into the supply.
How do they work? Do you kind of just stick it in the, if you're using, do you put it in the drugs and it shows up, or?
Yeah, there are a number of different techniques, but one in particular that's been explored in the last couple months has been these very small test strips that look a little bit like a small piece of paper that you create a small solution with water and dilute a little bit of the powder or pill to understand whether fentanyl is present. But other techniques could be a machine that doesn't require handling. So these kinds of ideas, and law enforcement actually uses many of these machines already, but public health doesn't, and nor do people who use drugs in the community on a large scale. So these are new ways that we need to evolve, much like we are for the treatment environment. Perhaps we need to be thinking about public safety, product safety, and another collaboration between public health and public safety and innovations.
So as we all know, this is obviously a national problem, but like you all said, the solutions tend to be very local, and each place needs to do something different. So Regina, as someone who worked on the federal level, we know Congress just passed a huge suite of bills before the election to address the opioid epidemic. How do you kind of, a lot of that money is coming from the federal level. How do you kind of address it broadly, but also address it very locally and get people what they need?
So the states, have a lot of leeway on what they can spend the money on. However, the SOR grants that are going out, it's $1.5 billion that will go out next year. The Strategic Opioid Response Grants. Thank you. So that money will go out next year. And those funds now must be tied to using medication. If you're going to use it for treatment, you have to provide medications if you're going to get funded under these grants. Now that's the first time. So, so there's kind of a baseline that will be set, that's been set by the federal government. And then the states can adapt it to the needs that the state has. Because as Tracy said, this is addiction is a geographic geographic, the drugs are geographically distinct, and so every state really needs to decide what it can do. The bottom line is, though, that the federal government and the states can have levers to make sure that the policies and programs that are put into place are science and evidence-based to the best extent that they can, that they know what they're facing. So the feds set the baseline and the states adapt to what's necessary. Mm-hmm. And the one thing I think that you hear from the entirety of the panel, and that the federal government money it can be spent on, because there's more than just funding coming from HHS, it's across the board, it's coming from Department of Labor, USDA, et cetera, is that we have to continuously identify intervention points and not be afraid to look at the criminal justice system is an incredible opportunity to intervene with people who may have chronic substance use disorders. So that those intervention points exist along the entire continuum, and so that's what states and local governments have to look at. Mm-hmm.
And, Dr. Mitchell, I want to talk to you about, obviously this epidemic, the overdose deaths are skyrocketing. We're seeing the highest number that we've ever seen. We know that medical examiners have been overwhelmed. I did a story earlier this year, and I talked to someone in Summit County, Ohio, and quote was, we're literally stacking bodies. Yeah. In West Virginia, they did not have enough room for bodies, and they had to have refrigerated trucks to keep all of the opioid overdose victims, before they could do autopsies. Can you talk a little bit about that? How medical examiners are overwhelmed, and how you're trying to keep up with all of this.
So the medical legal death investigation system in this country is split between a medical examiner and a coroner system. Some systems are coroner systems, and they tend to be elected or sheriff coroners. The other side is medical examiners. Those are appointed physicians, usually forensic pathologists like myself and my colleagues at the office. And the reality of it is that our standards of practice, because it is the practice of medicine, our standards of practice require us to keep a caseload, a particular caseload, about 250 cases per doctor per year. With this advent of the opioid epidemic, with this surge, most medical examiner systems and coroners are inundated, as you described, and are losing their accreditation or being placed in provisional accreditation. And on top of that, unfortunately, there is a medical examiner shortage in this country. A lot of individuals aren't going into forensic pathology as their career choice. And so we're trying to work and create innovative ways to discuss how we can increase the provision of these types of physicians and have these types of physicians go into this type of work so that we can deal with outbreaks like this and other outbreaks that we potentially will have in this country. So it's important, and fire and EMS are affected, and law enforcement are affected, and our public health system in general are affected. And most of all, our families are affected, right? Our loved ones are affected. And because these individuals are sons and daughters, their fathers and mothers, their cousins. And so we can't lose track of each one case is a devastation to that family and that community. And we work in, as medical examiners, we work in it daily, and really are the unsung surrounding the work that we're doing on a daily basis in working in this epidemic.
And it looks like we have a question from Laura on Twitter. Again, if you want to ask us questions, please do with the hashtag #postlive. Laura's question is, if you could have a set or points of data about this crisis, the addicts, the demographics, or other patterns that you currently don't have, what data would help you make the most impact in your work? Chief Simon, I'll ask you that question.
Yes, the non-scientist, the data question. We use data quite a bit, and it was kind of strange because I was not a data guy until I got involved in this. And what we're using data for, and University of Cincinnati is probably on the forefront of this, they've been able to pinpoint much of not just overdoses or crime where it's impacted, but many of these social issues. And what they're doing is they took a county in Ohio and were able to figure out within a 2-block area was most of the issues. And it wasn't always necessarily robberies or thefts. What it was their social issues with it, domestic violence, economics, poverty. And they were able to bring in these social networks and allow them to come in and intervene. A lot of times law enforcement is looked at as the ones to solve this issue. And I'm going to say this, we're not the ones that are going to solve any epidemic. A matter of fact, it is time that we stop viewing addiction as a crime and start viewing it as the mental medical health condition it is. I don't know why I, the first responder, am the one that is trying to heal mental health or addiction or some of these other issues. I should be the link to these experts, and these experts should be the ones to handle this. I'm not trying to shove this on to other agencies, but we don't have the tools or resources, knowledge, or skills to do that. They do. Allow us to be that link, allow people to get the care they need, and I think you would see what, no matter, the data then would change. The data would change, that we would have healthy systems, we would have healthy communities, and that's where we got to get to. We got to shift not just from data, and I caution data. Data doesn't tell the whole picture. There's a human side. And like the doctor said, it's really important that we never lose track that each one of those data points are a person. I've stood over the bodies of those people who have overdosed, and you said it exactly right. There is always a mother, father, brother, sister, son, daughter who stands next to me who will forever grieve that person. Never forget that that is not just a data point, it is a person. Bring those resources to the community, treat people like human beings, and I think we'll see a shift no matter what drug trend we're seeing.
And as you said earlier, you know, this is not only this is affecting generations, right? You have the foster care system is now overwhelmed from this. You know, schools are dealing with this. I remember doing a reporting trip once, and this teacher said, I just watched a 7-year-old tell me how to properly shoot heroin because she saw them have it in the home. You know, that this is really affecting, you know, just the fabric of communities and families and lives, and that's you know, an important thing. And I think, Joyce, you've been seeing that in Boston and Rhode Island as well through your work, talking to people who are using and their families as well.
Yeah, in fact, both to respond to you as well as the question from that had been coming to you, I think that we may be missing an important data point from the voices of people who are using drugs. We hear, sadly, from the decedents and from the emergency situations, from the arrests, but we don't actually hear from the people who are actually surviving and navigating and figuring out how to take care of each other. And we need to hear a little bit more about that, because from them we can learn both resilience that the Surgeon General spoke to at the individual level, but also at the community level. And those are important stories to be able to tell one another in times of crisis, but also it's important for us to catalog and make sure that we can respond and help give guidance to and provide extra services if we're not meeting their needs. So that requires a different kind of surveillance, probably and not the control surveillance, but rather the listening surveillance of actually talking to people who use drugs. If that's using ethnography, another one of our sciences, that would be fantastic. But this is a component that's really missing from a lot of our national approaches. But some states, and I'm proud that Massachusetts is one of them, is starting to do just that.
Yeah, that's right on point. So here in the district, as we developed our opioid strategic plan that will be published within the next 2 weeks here online and here in the district, we pulled together a group of not only experts in the field and agencies, but also survivors of their addiction to talk about what the policy should look like in the District of Columbia, how we should be engaging in a way that is meaningful for everyone involved. And so the voice of those that have been addicted cannot also be understated, and a lot of them also are the best substance use counselors, those individuals that are helping. So we do a lot of peer communication. We utilize peers that have been able to move from their addiction or on MAT or medical assisted therapy to talk to their other peers about fentanyl, about heroin, and about this opioid crisis that's happening in the district. So that's extremely important.
Just to be really specific and following up on Tracy's thread about who we should get more information from, we don't have good surveillance on incarcerated populations, nor for homeless populations, both of whom tend to have a lot of people with substance use disorders. So those are very specific areas that we should be looking at.
Okay, excellent. We just, is anyone, I know Chief Steinen, it seems like it affects the way that law enforcement works as well, you know, kind of more talking with people who are using and that sort of thing.
Well, I'm considered this expert. I became this expert because I talk to people that are using on the street and we find out the drug trends from them. It is a very important segment of society. And to us, I value their opinion because they tell me what's on the street. They tell me the trends. They tell me what to expect. And you're seeing a shift from law enforcement, not only with that health side, but there was a time when I've been stuck twice by needles. And now when my officers go out there, they just had someone who accidentally, luckily the cap was on, and that person was so apologetic and said, look, I know there's fentanyl on the street. I know hepatitis C and HIV. I don't want you being impacted by it. So you're starting to see this mesh, not just from the upper levels, not just from the system, but you're starting to see this mesh with law enforcement and those that are using. You know, unfortunately, it took over 70,000 people in America to die for us to shift our opinion on this. I hope that we do not go backwards and that we use this to go forward and that we take this view no matter what the drug is, no matter who the person is, or no matter what the addiction is, and move forward and change how we view and deal with addiction forever.
Fortunately, that is actually all the time we have. That went very quickly. So I want to thank Tracy Green, Regina LaBelle, Tom Steinen, and Dr. Mitchell for joining us. So thank you all for being here and tuning in, and we really appreciate it. Have a great rest of your day.
At a community center in New York City, Jamie Woods, battling drug addiction, slips into the restroom. She has 10 minutes. A monitor listens.
You all right?
Anti-overdose medications ready nearby if needed.
So that works for you.
This is the only place that I know that I can come and get straight because of my addiction, and I know I'm not going to die.
Staff here, along with mayors and health officials in 4 big cities and activists in other communities, want to help users inject safely out of the shadows by opening so-called safe injection or overdose prevention sites, medically supervised settings.
What we're saying is people that are already using drugs, they don't need to die in the streets. They don't need to die in alleyways because they don't have anywhere that's safe to use.
It's not lawful to facilitate the illegal use of drugs.
Deputy Attorney General Rod Rosenstein agreed to discuss this, warning of swift and aggressive action if any city opens an injection site.
They ought to be trying to persuade them to stop using the drugs and provide treatment and support.
They would argue they've tried that, but they just can't get people into treatment. We can't just do more of the same. Is that a concern of yours?
Well, I think it's always useful to try new and different approaches, but the approach of facilitating drug use, I think, is simply a form of appeasement.
Hello again, everyone. We are here now. Our third panel is on harm reduction. We are very honored to have with us Alex Kroll, Distinguished Fellow at RTI International, and David Murray, Senior Fellow at the Hudson Institute, where he co-directs the Center for Substance Abuse Policy. And Alex, harm reduction, it's a term, it gets thrown around in the whole opioid discussion. Could you start us off by telling us what does it mean exactly, and what are the elements of harm reduction, and which ones are you in favor of?
Yeah, you know, harm reduction is essentially just a set of practical strategies that are designed to reduce the harms of drug use. And so you might know them as anything from drug treatment programs like medically assisted treatment programs to syringe access programs, overdose prevention sites, you know, any of these kinds of programs that are essentially trying to minimize the harms. Of
syringe access, we mean needle exchanges.
Exactly.
Yeah. Okay, and fentanyl strips, allowing people who use drugs to test their drugs before they consume them.
Yep.
All of these things. So there's a spectrum in the harm reduction. Okay, there are a number of them that you are in favor of. Tell us which ones and why.
Well, you know, as a researcher, there's a number of harm reduction strategies that I've been evaluating over the years. I've spent the last 25 years doing research in the community and evaluating programs that are already being implemented in the communities. That includes needle exchange programs, as you pointed out. That has also included fentanyl test strips as well. You know, medically assisted treatment, you know, any of these supervised consumption sites, all of these are programs that are evaluated and at this point, yeah.
And what does the research tell us?
Well, I think what the research tells us in the U.S. is that syringe access programs have been incredibly helpful to reduce infectious diseases like HIV, viral hepatitis, and also link people to other services. I think that's something that was talked a lot about in the last panel as well, is that they're really a good access point for people to other kinds of, to see doctors, to mental health, to a whole host of services that we've seen. The supervised consumption sites, there's a lot of data from around the world, from Canada, from Europe, from Australia, where these sites have been for the last 30 years that are showing that they help reduce overdose deaths, they reduce HIV, hepatitis C, they facilitate people getting into medically assisted treatment, and they also reduce some of the sort of nuisance issues in the neighborhood. They reduce public injection, they reduce needles in the streets, and so this both, there's both help from the people who go there, but also it seems to help the communities as well.
Folks that don't know, supervised consumption sites are places where users can bring the drugs that they obtain on the street illegally and use them in a supervised setting. The people who are watching have naloxone in case there's an overdose. They have oxygen in case there's an overdose. And they probably are among the more controversial aspects of harm reduction. So David, simply put, harm reduction tries to keep people alive while they are using and before they can access or get into treatment. What could possibly be wrong with that?
I'm skeptical of the findings, and I'm worried that we're neglecting one of the critical tools here. Probably the single most effective overall strategic understanding of substance abuse disorders has to address the supply, the availability, the normative acceptability of their continued use. If you're not reducing the supply and availability, you're not enabling people to have incentives to move into treatment. Of the people who are in need of substance abuse disorder treatment, more than 90% are not seeking it. They're in denial. How do we incentivize them to seek treatment and get into recovery from the disease of addiction if we're enabling them to continue to use by setting up facilities that enhance their capacity to get access, that removes the criminal justice system from its presence there? We don't avail ourselves of the tools that drug courts could bring to bear. We don't avail ourselves of the efforts to reduce the sheer availability and supply of fentanyl, for instance, from China, which we're recently working on. And the last thing, I suppose, is this concern. There is both a social policy dimension to this notion that the state or the society becomes the enabler and sustainer of continued drug use by enabling the injection of either illicit heroin or in some instances, such as in Canada, where the state provides the heroin. And so they make sure that it's clean and pharmaceutical grade. But what you're doing is you're enabling a lifetime of addiction. These drugs are themselves not safe. Over time, the impact on the user, who could be moved into recovery, who could be brought home and into our families and lives again, is sustained in exposure to things that undermine their immune system, things that reduce their mental capacity, things that threaten their lives. They're not safe, even when they're injected with somebody supervising standing by.
David, are we enabling them, or were they going to use those drugs anyway, and we're just providing them with a clean place and a healthy place to do it?
A clean and healthy place to inject a poison is somewhat problematic from a public health point of view. What you actually see when you study these facilities is that they're not giving you the full story. They're methodologically a little unsound. There's huge attrition problems with studying these populations. There are huge difficulties with interpreting what is the goal and what is the measure before we say injection facilities work. What we really see, excuse me, in extremely problematic populations, such as in Vancouver, 25% of the people who are seriously participating here are Indigenous, by the way, and they're poly-drug abusers. They're mixed substance disorders here. People are simultaneously using high-potency marijuana, methamphetamine, cocaine, crack cocaine, and the opioids. You can't simply address the opioids with a naloxone recovery and think that you have a solution to the problem. This is more of a dodge. Naloxone is extremely important. It can save a life in the immediate context. It must be an occasion to try to get somebody. It's a rescue operation to get them then into treatment and recovery.
Well, perhaps the treatment's not available. In this country, it's very difficult.
The majority of people are not pursuing and trying to find the treatment that is available. Certainly expand treatment. As best we can, make that outreach available. But you see how counterproductive it is to say, you can either get into recovery and treatment, the hard choice. You can go on to medication-assisted therapy where you're taking buprenorphine, which can sustain you, or you can just give up and we can provide you with a clean facility where you can continue to get illicit heroin. Now let's be serious about this. There's very low participation rates. Of the available population that is at risk for substance abuse disorder, the people who actually show up and show up consistently at the injection facilities is actually very small. And unfortunately, they're not consistent users. How much are we really protecting them and saving them? They say, well, overdoses in the facility are not found because someone's standing by with a naloxone. Yes, but what happens, these people continue to use on the street with illicit heroin. Dealers gather in that area because law enforcement has been told to disattend to the presence of heroin in that circumstance. You're enabling and sustaining a market of illicit heroin where the users who participate in the facility continue to expose themselves to HIV, to hepatitis, and continue to expose themselves to the risk of overdose when the facilities are no longer used or available or closed. They continue this behavior. You haven't changed their behavior towards recovery.
How about that? Are we enabling drug use through supervised consumption sites?
No, the data does not show that you're enabling it. It's not increasing the amounts of people who are using it. The people don't use more who go to these sites, and so it's not enabling drug use in that way. What the data shows is that these sites actually do facilitate. This is what we actually need is you need a way to get people to treatment. And as Dr. Murray says, it's tough. Not everybody wants to go to treatment or can do that,
sure,
like you were saying as well. And so this is an access point, just like syringe exchange programs are an access point. So it's a place where you can actually start that conversation, talk to somebody and say, hey, are you maybe interested in something like this? Because it takes time. And what we've seen is this is a recurring, opioids, it's a very difficult thing to stop using. People go to treatment and they might start using again. It's a recurring thing. And so we need somewhere in the community for people to actually talk that's free of a stigma about them even coming there. And they feel like they're safe and they can actually, start thinking about ways that they can change, behaviors in their lives that they'd like to change.
Now, British Columbia, which I dare say probably has more of these kinds of places than any other part of the world. There's quite a few supervised consumption sites, still has an overdose problem. So are we not getting people from these sites to treatment?
Yeah, that's a good question, and I've seen some misconceptions about that in the media lately as well. And so what you had was the main site in Vancouver, Insight, opened in 2003. That's a long time ago now. It's 15 years ago. And they did, really incredible evaluations there. They published in the top medical journals, New England Journal of Medicine, British Medical Journal, all these top journals. And essentially, what they found at that point was that it did reduce overdoses hugely at the time, right? But then what's happened in the last 3 years or so is that we have this new fentanyl epidemic, right? And this fentanyl epidemic has come to Vancouver, unfortunately, just like it's come to all the United States at this point, right? And so you've got increases in overdoses in Vancouver, because of that same epidemic that we're dealing with here. The site is still reducing mortality by saving all the people who are actually in. I think they actually save about 6 people a day.
So it would have been a lot, once fentanyl arrived, it would have been a lot worse than what we're seeing had it not been for these sites.
Exactly.
Okay. David?
I disagree. I think that they have been coincident, these sites and harm reduction activities, with the very catastrophic epidemic that we have seen. They've gone hand in hand. I'm not saying it's causal, but they are clearly related. In the last 8 years of the Obama administration, and I worked under the Bush administration, I worked under the Obama administration, I served in both, I saw what happened in terms of policy. We've seen a retreat from a strategic understanding of the role of supply in trying to inhibit the availability and to change the norms where people can be moved into recovery effectively. A retreat from that is exactly coincident with a catastrophic rise from 2010 until now of the opioid overdose epidemic. Same thing in British Columbia, 80% year-over-year rise of overdose deaths because they continue to use and expose to a highly dangerous substance that is lethal. And unfortunately, we're discovering further naloxone is refractory. That is, the fentanyl that they're taking is so powerful, so overwhelming, that many times it requires multiple doses to recover. If the naloxone is not being made available for overdose recovery in the hands of supervised professionals, in the hands of EMTs or law enforcement, or ideally medical personnel, you're missing the opportunity to move these people to recovery. You may be saving a life, but what you're really doing is deferring the overdose that will subsequently still be a risk for them when they have recovered. There must be more strategic ways of changing that dynamic, changing the behavior, enabling entry into treatment and retention in treatment. And the studies that seem to show that safe injection facilities, quote, work, are really very modest in terms of what their goals are. They say compared to, say, methadone, there's longer retention in treatment if we give them actual heroin itself. That's a very modest goal. They're not moving people towards recovery. They say, well, there are access points where you can get people into treatment. You actually study how many referrals into treatment are actually successfully completed in these facilities. Virtually never. What you get is sometimes a detox referral. You do not actually get movement of people off the streets into recovery. And again, the polydrug act, one last thing, this really isn't critical. It's polydrug use. We have medication-assisted therapy for opioids. We do not have medication-assisted therapy for methamphetamine, for cocaine. These kill. And the comeback of cocaine out of South America into the United States scene in the last 3 years has been extraordinary. It's rising steeply year over year. We're now losing 10 or 1,000 more people a year to cocaine overdoses. There's no medication-assisted therapy there. There's no solution with a safe injection facility where someone stands by with naloxone for methamphetamine injection, for cocaine injection. And when they're combining that with the opioids, the lethality will continue. This is a substance abuse disorder that we have been enabling further by the legalized access of recreational marijuana at high potency at a young age, which is setting the foundation for this.
Thanks. Alex, it seemed like you wanted to respond.
Well, I think there's a lot to respond to there, honestly. I think in terms of naloxone, I think we heard earlier from the Surgeon General that we need to not just have naloxone in the hands of EMTs, of law enforcement, because they might not get there in time, right? Like he said, I think 4 or 5 minutes. You know, that's a tall order, especially in rural areas, especially in places not in the middle of the city. And so we do need naloxone, I think, in the hands of really of every American, honestly, as much as we can. It's inexpensive. There's no risks associated with it. You know, we were the first people to actually evaluate community-based naloxone back in 2001. We conducted the first pilot study of this, and I think that's the thing I think we need to think about here is we've seen over the years. We've seen, you know, with the HIV epidemic, that was a huge problem. We needed to think about new solutions at the time. We couldn't just say, okay, let's stop drug use. I think we did a lot of supply side at that time, and that didn't change that. It didn't change the HIV epidemic.
So that's why we came up with needle exchanges, naloxone distribution.
Which is something that came from the community. The community thought of this thing. It was evaluated by researchers, and then once it was shown to be effective over time, then governments decided, okay, this is something we need to fund and we need to do. The same thing is true with naloxone.
Fentanyl strips is happening now, right?
The same thing is true as naloxone, right? So that's something that came from Dan Big in Chicago, really a hero, frankly, who said, you know what, we need to give this to the people. So he, in the late 90s, he's the one who started training people and doing that. And then we did the research on that to show that it actually works. And then now it's a pillar of the current administration. You know, it's very important. So we need to think about this in terms of needing some of these innovative strategies, allowing them to happen as sort of social experiments, really. If they work, then we need to, you know, that's how we're going to stem and not sit here with 70,000 Americans dying in the next year, just like as they did last year.
David, the law that makes supervised consumption sites illegal in the United States was passed in the 1980s. It was mostly aimed at crack houses. It was a way to try to keep people from opening crack houses or using drugs in crack houses. I don't think it was ever intended to keep volunteers and medical professionals from setting up a site like you guys have been describing to keep people alive before they go into treatment. Why do we need this law? Why don't we try to do something about that so that people can do pilot projects and not be in violation of federal law.
I'm not opposed to using naloxone, by the way. I mean, this is an important tool, and it has intervention capacity. It actually does save a life where possible, and it should be under medical supervision, and ideally, because you only have a few minutes to get a person into recovery and ideally a transition to treatment, and then they're still at risk again. Nonetheless, it is not a solution. It's not a strategic solution.
Right.
It's a dodge.
We understand.
In no other disease do we take a person and let them run with the disease until they finally collapse in the street and then say, oh, we must intervene here. We need a strategic solution that works more broadly. And let me make sure this is clear to people. We usually dismiss the notion that supply reduction can have a strategic effect. No one who served in the White House office, as I did during the years when we cracked down on, of all things, cocaine, and made major dramatic international changes in the availability and supplies, 75% reduction in the availability of cocaine coming out of Colombia that had massive and beneficial effects on U.S. streets.
David,
recovery was strong.
The federal law.
Overdose deaths decreased, and the reduction in supply has strategic impact. The federal law, if you can change it if you want to, say, for instance, that this is a Schedule I substance, which is illicit to have under federal law, and that's why you cannot bring illicit heroin into a facility and inject without being in violation of federal law. I heard Assistant Attorney General Rod Rosenstein just suggest that this needs to be perhaps addressed, but you cannot simply move heroin around with the presumption that you're immune or have impunity from the legal system without untoward and unintended consequences.
Well, you can
facilitating greater heroin availability for those who use illicitly.
You can if you do as they do in Vancouver, where the government supplies pharmaceutical-grade heroin.
Yes.
And for users, I went up there and toured that site and spoke to people. For users, that has been a godsend because they can hold a job, because they can pay their rent, because they're not committing crime to get money for drugs. You could actually do that.
Well, we've seen that. I visited Insight in 2003 and then saw it again when we were in office. We went to Amsterdam. We saw such facilities before. There's a little bit of an illusion about what happens here. A heroin injector is a hardcore, long-term, chronic heroin injector is injecting multiple times a day. Basically, they're in a daycare facility receiving government heroin paid for by taxpayers, and that really questions and constrains their citizenship. How free is this person who's now dependent on heroin that the society is supplying? You say, well, they're good at job. Well, they're multiplying multiple times a day they're having to inject, and they're still at risk from the drug itself. Under this circumstance, that seems to me to not be a free citizen. That seems to be a citizen on a leash. Do these people, are they enabled to drive school buses, to participate in flying an aircraft, to have professional lives? Well, no, because they're dependent and they're basically disabled under the drug use that we're trying to get them free from. But is this the policy you would want for your sister, for your son, for your own family members, that they are being warehoused effectively somewhere by given government-sponsored heroin so as to keep them from disrupting the local neighborhood?
No, they go out into the
strategic solution.
They go out into the community and hold other kinds of jobs. Yes, they're not driving buses. But
I'm feeling a lot of stigma attached to all the things you're saying there. I mean, I think that people who are on various medications, whether that be methadone, whether that be buprenorphine, or there's all kinds of medications that people are on, and I don't think that it sort of warehouses them in any kind of way. I think, you know, what the research shows is that this actually improves their lives, right? And it does reduce their likelihood of dying. It does reduce their likelihood of getting infectious diseases, you know, overdosing, all these various things. And so I don't think we can just say, well, you know what, that's a problem. They just got to sit here in their warehouse in this sort of way. I think we have to deal with people in the community and think about the person on the street, think about people in their homes, and how can we actually improve their lives in some sort of way. And some of these harm reduction strategies, whether they be overdose prevention sites, you know, or safe injection sites, or whether they be needle exchange or naloxone, fentanyl test strips, there's a lot of different ways that we now know that are solutions to actually improve the lives of folks, and that's what the science shows.
No, I completely agree with you with regard to buprenorphine. That is a proper and is a way of maintenance, and as long as it has the goal of recovery, seems to me to be very viable, and the data are good on buprenorphine. I was talking with warehousing as a reference to the government supplying pharmaceutical-grade heroin as the treatment for heroin disorder. That seems to me to be a very different equation.
All right, I'm going to ask you guys, and it's given our time, it's going to have to be a very brief answer. Yes or no, and maybe a few seconds of explanation. Is someone going to open a supervised injection site in the United States and test that law and test the Justice Department's promise that they will crack down on it? Yes or no?
We've got 70,000 people who died last year. I think we need to look at innovative solutions to see if they work. We can't be afraid of starting something just to try it at least. So yeah, I do think that there's going to be cities. There's several cities that have said they're going to try to do this. Philadelphia, New York, San Francisco, Seattle.
And they'll provoke a court test, presumably.
I think, you know, I don't know about that part, but I think we need to test them to see, do they work? Do they work here? Or is that good for these communities or not?
David?
This is not a good public health solution. I think it probably will be tried somewhere. This is a social engineering experiment. We have better solutions, better strategic capacities to get these people into recovery and to liberate them from their own disorder and get them home again. And I think we should prefer those strategies before we move to injection facilities that we maintain. Thank you.
Thank you, guys, for this very vigorous debate. That's we're out of time. Alex Kral, David Murray, really interesting thoughts on harm reduction. Thank you very much.
Thanks, Lonnie.
Coming up later today here on C-SPAN 2, Lael Brainerd, a member of the Federal Reserve.